Welcome, colleagues. Today, we're diving deep into endocarditis, a formidable infectious disease that directly targets the heart. We're going to explore its pathology, the intricacies of diagnosis, and the critical treatment paradigms we rely on.
So, here's our game plan. We'll kick things off by defining the disease itself. Then, we'll get into the nitty-gritty of diagnosis and pathogen identification. After that, we'll cover our treatment arsenal, public health considerations, and the scary systemic complications, before we wrap up with a case challenge to put it all into practice.
All right, first things first. Let's define exactly what we're up against. Endocarditis is a truly formidable pathological process, a direct assault on the inner sanctum of the cardiovascular system. At its core, endocarditis is an inflammation of the endocardium, which is the heart's inner lining. But the real danger, the reason this is so lethal, is its tendency to attack the heart valves. Pathogens set up shop there, forming these destructive clumps of bacteria and fibrin that we call vegetations. Left unchecked, this process leads to abscesses, valve destruction, and ultimately catastrophic cardiac failure. Now, it's absolutely critical to distinguish between the two main ways this disease presents. Think of acute endocarditis as a violent, fast-moving storm. It hits hard and fast with severe sepsis, and it's often driven by a really aggressive bug like Staphylococcus aureus. On the flip side, you have subacute endocarditis. This is more of a slow, smoldering fire. The course is protracted with vague symptoms like malaise and low-grade fevers, typically caused by less virulent organisms like Viridans streptococci.
And beyond just acute and subacute, there are these key categories we have to be aware of. Prosthetic valve endocarditis, or PVE, is a real beast to treat because bacteria form these slimy, protective biofilms on the artificial material. Then there's HACEK endocarditis, caused by a notorious group of picky, hard-to-grow bacteria that originate in the mouth. And finally, right-sided endocarditis, which you will almost always see strongly associated with intravenous drug use, as pathogens get a direct route to the tricuspid valve.
Okay, so you suspect it. How do you go about proving it? A precise diagnosis and, critically, identifying the causative pathogen. That's the absolute cornerstone of managing this disease effectively. Everything, and I mean everything, begins with a meticulous blood culture protocol. For subacute cases, you have some time, so you draw 3 sets spaced out. But for acute cases, the clock is ticking. You need to get 3 sets within 2 hours, and this is non-negotiable, before you start antibiotics. Then you tell the lab to hang on to them. All cultures need prolonged incubation, up to 14 days, because we're hunting for those slow-growing, fastidious organisms that won't show up overnight.
But here's the kicker. Even when you do everything perfectly, in about 5 to 10% of clear-cut clinical cases of endocarditis, the cultures come back negative. Nothing grows, and that presents a massive diagnostic headache. So that brings us to the million-dollar question, right? Why? Why do these essential cultures sometimes fail us and remain stubbornly negative?
Well, there are a few key culprits. The most common one, by far, is prior antibiotic use. The patient got a dose of antibiotics in the emergency room or from their GP, and it's just enough to suppress bacterial growth in the lab. Other reasons include just plain old inadequate culture technique. Then you have those fastidious bugs we mentioned, like the HACEK group, that just refuse to grow on standard media. And finally, you've got the true phantoms of the microbiological world, obligate intracellular pathogens like Coxiella and Bartonella. These guys live inside our cells, so they will never grow in a blood culture bottle. You need special serology or molecular tests to find them.
The other pillar of diagnosis is, of course, imaging. And the choice of echo here is just night and day. Look at this chart. The sensitivity of a standard transthoracic echo, a TT, is frankly abysmal. It can miss 3/4 of cases. But a transesophageal echo, a TEE, it's a completely different story, with sensitivity soaring up towards 100%. TEE is absolutely indispensable if you have high clinical suspicion, a prosthetic valve, or if you're worried about complications. In fact, it's been shown to pick up endocarditis in up to 20% of patients who had a negative TTE. It's a real game changer. So, with the diagnosis in hand, or at least a very strong suspicion, we pivot to our therapeutic arsenal. And make no mistake, treating endocarditis is a marathon, not a sprint. It demands a complex, highly coordinated, multidisciplinary approach. The core principle is unwavering. We have to be aggressive. This means long-term, high-dose, intravenous antibiotic therapy. The standard duration is 6 weeks. And here's a critical clinical pearl. Day 1 of that 6-week clock starts on the first day your blood cultures turn negative. Or, if the patient goes to surgery, it's the day of the operation, assuming those intra-op cultures were positive. While you're waiting for those culture results, you can't just sit on your hands. You have to start with empirical therapy, and your choice is guided by the clinical picture. For a sick patient with acute native valve endocarditis, you're betting on Aureus, so you hit it hard with high-dose flucloxacillin. But if there's a prosthetic valve in play, you need broader coverage. You're worried about coagulase-negative staph, so you reach for vancomycin to cover all your bases. Now, once the lab calls with a pathogen ID and its susceptibilities, we can de-escalate. We move from our best guess to targeted pathogen-directed therapy. And you can see here just how nuanced this gets. For a straightforward penicillin-susceptible strep on a native valve, maybe 4 weeks of ceftriaxone is enough. But for an MSSA on a prosthetic valve, you're pulling out the big guns, a 6-week triple therapy combo that includes rifampicin specifically to penetrate that nasty biofilm. This is where the real art of infectious disease management comes into play. Effective management doesn't just stop with treating the individual patient, though. It has to extend into the much broader context of public health, disease surveillance, and infection control. Certain pathogens that cause endocarditis are legally notifiable diseases. And this isn't just bureaucratic box ticking. Reporting an organism like Coxiella burnetii, the cause of Q fever, is absolutely vital. It's the lifeblood of public health surveillance, allowing authorities to track trends, identify potential outbreaks, and ultimately protect the entire community. There's a quote that I think captures the challenge of this perfectly. It says that infection control can feel like trying to herd cats. You get one problem under control and 3 others pop up somewhere else. But as the quote so humorously points out, unlike cats, our pathogens are invisible, which just makes the whole endeavor that much more interesting. It really requires constant vigilance. And now we have to turn to the darker side of this disease. We need to talk about its potential for truly devastating, far-reaching consequences that can ripple through almost every organ system in the body. The impact can be absolutely catastrophic, and it starts with the heart itself. The infection can literally chew through valves, causing acute heart failure. It can burrow into the heart muscle, forming abscesses that trigger lethal arrhythmias. But the damage doesn't stop there. Bits of those vegetations can break off, becoming septic emboli. If they go to the brain, you get a stroke. If they go to the spleen or lungs, you get infarcts. The bacteria can set up shop anywhere, causing metastatic infections in joints, bones, or even the brain. And the whole thing can culminate in overwhelming sepsis, septic shock, and multi-organ failure. Okay, that was a lot of information. Let's try to consolidate it now and apply this knowledge with a quick case challenge. Here's the scenario for you. You have a 45-year-old patient with a known history of intravenous drug use. They come in acutely ill with fever and shortness of breath. You suspect native valve endocarditis. So what's your #1 most likely pathogen, and what antibiotic are you starting empirically? If you said Staphylococcus aureus, you are spot on. In this clinical context, S. aureus is far and away the most likely and most dangerous culprit. Therefore, your empirical therapy of choice has to be high-dose intravenous flucloxacillin. This gives you fantastic coverage for S. aureus while also covering your bases for streptococci, just in case. And this brings us to one final and frankly rather sobering thought. As we look ahead at the relentless evolution of antimicrobial resistance, from MRSA to VRE and beyond, which of these treatment paradigms that we've just discussed is most at risk? The very foundations of our therapy are being challenged every single day by microbial evolution, which means we have to remain constantly vigilant, relentlessly innovative, and forever students of this fascinating and formidable disease.